Yes, I'm going to talk about the Mite allergic rhinitis and allergen immunotherapy for or allergen reduction. And for this talk, I have some conflict of interest because I did some study. Will show some study with ALK and also with allergen, I think so. Yeah. So first, immunotherapy for Mite and allergic rhinitis and asthma. Here, I will show you the data obtained by one laboratory because, in fact, because of these studies, desensitization for asthma, for allergic asthma, for Mite allergic asthma, now is possible according to GINA guideline. If you look at the, yes, you have different studies, and there is one study for the phase 2. I will show you that. The first study was MTO2. It was an asthma, Mite allergic asthma in adults. Then after, and there was two kind of study: the post-hoc MTO2 for allergen rhinitis, and MTO2 for Mite allergic rhinitis. And then after, this is the phase 2, and then we are in the phase 3. You have Mite, which is the pivotal study for allergic rhinitis, and phase another study in the chamber for allergic rhinitis, and MTO4 for Mite allergic rhinitis. About Mite, about the measure. It's about the Mite allergic rhinitis. The patients were aged from 18 to 65, and they had Mite allergic rhinitis, and they were symptomatic despite the treatment. And at least they need to have one criteria from ARIA corresponding to an impact for the quality of life: sleep, alteration of daily activity, alteration of activities at work or at school. Some of the patient could have asthma. They could be asthmatics, but with GINA 1 or 2. And they had a positive skin prick test to Mite and specific IgE to Mite also. Here is the description of the study. You have, so it's more than 900 patients. You have the first period, and then you have the randomization, and the study lasted 52 weeks. 2 doses and placebo, and every 15 days there was a log pad in which you gathered all the data concerning the score, the clinical score, and the medication score of the patient. And then this is during the desensitization, 10 months, and then after 2 months, every day they register the data of the patient. Here are the demographic of the patients, and you can see, so 992, three groups, and the discontinuation are the same, the same in the 3 groups. And here also you can have an idea about what kind of patient they have. So how's the Mite allergic asthma in 46% of the patients, and they were monosensitized for only 30% and polysensitized for 60%. You know, this idea about the desensitization only for monosensitized patient is not a true idea, because in the real life it's like that. You have 1/3 of the patient who could be monosensitized to Mite, and the other are polysensitized. They are allergic to sensitized to cat or to pollen, grass pollen or birch pollen. You have here the symptoms of the patient, also the rhinoconjunctivitis and the conjunctivitis, the 3 group. You can see that the score was completely the same in all groups. And here are the results. Yeah, you have 9 months, and it's at 15 weeks, you obtain a significant effect. So desensitization, sublingual desensitization, just with the tablets, after 8 weeks, 15 weeks, so 14 weeks. Well, I really right. Yeah, sorry, 14 weeks. You have a significant effect, but the effect was. This is at 1 year. The effect was important at 1 year, was the most important. But you can see that after 14 weeks, you have these results. And this is, well, we know more and more about that desensitization could be useful, could be efficient very soon, within 3 or 4 months. These are the results that all the different, the subgroup analysis. And you can see that this is the value, the drug of the different dose, 6 and 12 DU, and you have the gender, there is no differences, and all this, you can see that there is no difference according to desensitization, if they are monosensitized or polysensitized. Now, this idea that monosensitization, desensitization is better and works better, it's not true, because we did not find that. About the tolerance of the patient, and the adverse effects are really the same. And as you can see, they are mostly oral pruritus, which is known because when you are using just a tablet, a sublingual tablet, of course, it's itch, and this is normal. And usually it lasts 6 weeks or something like that. About the exposure chamber, it's the rhinitis. It's not in Strasbourg. This was performed in Vienna, in the chamber in Vienna. Oops, sorry. So what is the design? You have 124 patients, 3 doses, 12, 6, and placebo, 2 doses and placebo. And this is the session in the chamber before, after 8 weeks, 16 weeks, 24 weeks. And we assess the TNSS, the total nasal symptom score. It's a score about 12, and it comprised the itching, sneezing, nasal obstruction, and nasal secretion. So look at the TNSS, and as you can see that after 16 weeks, we have a significant effect. The black is the placebo, the yellow is the 6, and the red is the 12. And you can see that we have a decrease in the TNSS by 18% for the 6SQ dose and 30% with the 12SQ dose after 16 weeks, 4 months. So the sublingual immunotherapy is efficient. After 4 months, you can obtain results. And then at 24 weeks, you have a decrease by 49%, which is pretty high, but it's normal that you obtain better, higher results in the chamber as compared to the in-field studies, because in-field study, it's around 30%. Here, it's 49%, but it's a good results and very interesting. This result confirm the pivotal study. About asthma, I put this slide just for you. It's a very old study, serious, 1999. And if you look at that, you can see the chance when you are sensitized to all these allergen, the chance to have asthma symptoms at any age, to have hyperresponsiveness, and to have hyperresponsiveness and symptom of asthma. And if you look at that, you can see that, for example, when you are sensitized to dog, the odds ratio to have symptoms is 1.4. The risk for having hyperresponsiveness is 2.5. The risk having hyperresponsiveness and symptoms is 3.6. Now, if you look at how's the Mite, it's higher. So clearly, being sensitized to Mite is a risk factor for asthma. Mite allergen are asthmogenics. And of course, I don't want into details, but I have a talk about that, about the effect of Mite, because Mite they can, of course, they are allergens, but also they have non-allergenic properties, and they can stimulate the innate immune system directly. And this is the difference with other allergens. You can see also in this slide, this is also interesting, that Aspergillus fumigatus is the only one which is more allergenic, more asthmogenic than mite allergen. To show you this are the meta-analysis, and all these meta-analyses were performed before all the program for mite allergic asthma in adults. This is the result obtained in children. So children with a mite allergic asthma and sublingual desensitization. And this is the results with adults, only one study. So the data about this sublingual immunotherapy in mite allergic asthma in adults were very poor. It is why, and it's very interesting because even that, their recommendation, this is the recommendation from the German, Austrian, and German-Swiss speaking part about desensitization for mite using sublingual administration before all these studies, the studies that I'm going to show to you. And you look at that. If the patient has a bronchial asthma, partially controlled or uncontrolled, it's a contraindication. But they allowed to perform sublingual desensitization in controlled asthmatic patients. And this is the second point. First, there were very few studies demonstrating the efficacy of mite desensitization in adults with asthma. And secondly, if you want to perform a desensitization, patients had to be controlled. And I will show you that now it's not so true. So this is the first study that ALK did with a tablet, Mitizax. At this time it was Mitizax, now it's Acarizax. And it was a phase 2 study for the first time. And I have the opportunity to be part of the board who decided the design of the study. And it was 600 patients. They were mild, moderate, persistent asthma, GINA 2 and 4, under inhaled corticosteroid, 100, 800 microgram per day for more than 6 months. They had to have an ACQ less than 1.5 at the randomization. So control or partially control asthmatic patients, FEV1 more than 70%. They could have also a rhinitis. They had to have a specific positive skin test and specific IgE. And the idea was to assess the efficacy of the desensitization by the change from baseline in the daily inhaled corticosteroid dose needed to maintain asthma control. Here, the result that we obtained with that, yes, the result obtained was in fact the decrease in inhaled corticosteroid. Sorry, I forgot one slide. In the first study published by Mosbeck, the decrease of inhaled corticosteroid was 80 microgram of budesonide, which is almost nothing, because if you ask for an adult, 80 microgram is nothing. But we perform a subgroup analysis, a post-hoc analysis, and in patients, though the patient who had the highest dose of inhaled corticosteroid from 400 to 800 microgram of budesonide, with an ACQ, the worst one, from 1 to 1.5, this patient, the reduction, instead of 80 microgram, the reduction, this is the reduction that we obtained in the first study. In the second study, the reduction was 300 microgram of budesonide for patient from 400 to 800. So 1/3 of the dose you could reduce 1/3 of the dose. So at this time, we're very happy because we consider that these patients are the target for the pivotal study. And the pivotal study was this time also there was a study from allergen, again with tablet, a sublingual tablet, more than 400 asthmatic patients. The study was performed in China for a 12 months desensitization, and they did not find any difference between active and placebo, but during the post-hoc analysis, they found exactly the same profile, 400, 800 microgram equivalent beclomethasone, and they found that in this group, there was a significant difference. So clearly, we found that the target population for desensitization in mild allergic asthma in adults was mostly patient GNR 3 to 4, partially controlled. And this is the MT04, and MT04 was published in a journal in JAMA, and I was the last author, and the first author was Christian Virchow. Yeah. So they had to have a reversible airway obstruction. Can you see that? They have a GINA guideline. They have to use inhaled corticosteroid according to GINA guideline step 2 to 4, and they switch to 400 and 1,200 microgram per day. They have an asthma control level corresponding to partly control at randomization, and this is very important because at this time, remember, it is impossible. Before, we always say that it's impossible to desensitize someone, an asthmatic patient. The patient has to be controlled. In this case, they were partially controlled. FEV1 more than 70%, and that means that 72% had partly controlled, and 28% were uncontrolled. So almost, at least not 1/3, but 28% were uncontrolled when we began when the patient were undermined. This is the design. More than 800 patients, 12 and 6 SQ placebo. And the patient at the beginning, for 5 to 7 weeks, it's the screening period. For 12 months, the patient was desensitized, but at the end of that, we had the idea about the status, if the patient was controlled or not controlled at this time. And then after the third period, it's the ICS reduction. And I included some patients in this study, and I was really I worried about that, because at the first it was a 50% reduction, 50% reduction, but at the end it was completely stop, 100% reduction of inhaled corticosteroid. So I worried about our patients, and the idea, the principal objective was to see the time necessary to obtain the first exacerbation during this period. So you reduce, the patient here is not very well controlled. Then you decide to reduce the inhaled corticosteroid by first 50%, then 100%, and you look at the time necessary to obtain the first exacerbation. Yeah, 50% reduction, 100 reduction. This is no, I think this is not. So 48% female, 12-year duration, 66 were sensitized to Mite. Again, is the same. 2/3 they are polysensitized, and the other are monosensitized. And you can see that all the sensitization, Mite, tree pollens, grass pollen, Artemisia, horse, dog, cat, whatever, but they are polysensitized. And this is the results. The measure that time to first moderate and to severe exacerbation. And for the first time, we demonstrate that desensitization to mite is efficient in mite allergic asthma in adults, and particularly on the most stringent, on the most difficult factors is the exacerbation. Because it was the agency who asked to a major objective to reduce the exacerbation, and you can see that the hazard ratio was 30 by 1/3. We reduced the exacerbation by 1/3. This is the placebo, and this is the 2 doses. There was no difference in the 2 doses. This is also the secondary objective. The deterioration of symptoms, it was significant. And you can see also again, this is the placebo, and it's a Kaplan-Meier curve. And you have also the same, we have a significant reduction for the 12. The increase of SABA, you have also a significant effect for the 12. The deterioration of lung function, you have also a significant effect for the 2 doses, but for severe asthma exacerbation, it was not significant because there was not enough severe exacerbation. So, because of this study, the sublingual immunotherapy using the tablet was added since 2017 in the GINA guideline, and for the step, in fact, it's step 4, 3, and even before, it's allowed to desensitize in mite allergic asthma in adults. Allergen reduction, about allergen, because I wanted you to show you on a few slides, but we can discuss that after, it's not a problem. My feeling about what are the right patients to perform desensitization. And I prepared some slides, but maybe I was confused, I don't know. Maybe we'll see after. Allergen reduction. Allergen reduction, if you look at the meta-analysis published until 2008, it's negative. It's not necessary to perform allergen reduction in mite allergic asthma. But meta-analysis with allergen reduction studies are very heterogeneous. And you know, when you perform a meta-analysis, what is very important is the size of the study included in the meta-analysis, and also the heterogeneity of the studies. In this case, they are very small and they are very heterogeneous. So it's very difficult to perform a good meta-analysis. And also in those meta-analyses, they did not include the multi-facet intervention study. And it is why I'm going to talk about allergen reduction. Why certain studies are negative? Because it's the failure to adequately reduce mite allergen level. Measurement of the allergen exposure is not precise. Allergens are not only concentrated in the mattress dust. Allergen reduction, and this is one key message, methods must be global. The individual susceptibility might be considered. Reducing exposure, reduce exposure to allergen, but maybe to other pollutants. And also the response to individual domestic allergen may differ. So I will show you first a negative study published in a respectable paper in the New England Journal of Medicine. It's an English group, Ashley Woodcock and Anna Kustovic, and they perform a study in adults. And this is very interesting because after they publish another study 10 years or 14 years after, and you will see the results. 1,000 adults, just encasing the mattress, they are considered allergic to mite allergy. They have a positive skin test to mite, but they did not perform any yes, they performed the skin test to other, and 25% of these patients were allergic to cat. And we don't know if they have cat or not, if they had cat or not. They measure the mite allergen in only 10% of the patients, and they look at the clinical score, the medication score, the exacerbation and hospitalization count. And the results, at 6 months, they obtain there is a significant reduction in mite exposure. In the study group, it's 0.58. In the control, it's 1.7. So it was significant at 6 months. But at 12 months, it was not significant. So in fact, it was not a reduction study because they did not obtain a reduction at 12 months. And it was a negative study. And then after, it's just at the same period, we developed a new job, which we talked about that yesterday. It's the medical indoor environmental technician. I created that with Mrs. Ott in 1991, so more than 30 years. And we published this paper, 378 patients, Marseille, Montpellier, Paris, Strasbourg, and 189 patients with an indoor technician and the other without the technician. These doctors, because it's patients, but also doctors, they are allergists alone or allergists plus the indoor technician. And we look at the global allergen avoidance, that the compliance, to look at the compliance, and the compliance was higher when the allergist has the medical indoor technician. So the patient see the allergist, and the allergist in the group with the technician, the technician, she or he went to our dwellings and give advice. And also we obtain a mite allergen reduction significantly higher in the group with the indoor technician in the mattress base and the floor dust. So for the first time, we demonstrate that having someone who goes at home, who give advice according to what she sees, it's more efficient in terms of compliance and more efficient in terms of allergen exposure. But we did not perform the clinical part. And this is the result that we obtain. This is the group A allergist alone, group B allergist alone plus the indoor technician. And you can see washing the pillow, washing the duvet. Another point which is very interesting in this study, in the group A, the allergists were helped because we gave them a list of advice that they can give to their patients. But in fact, the advice were wrong in 75% of the case. That means when you see a patient, when you want to give advice to him about his dwellings, it doesn't work because you don't see really what's going on at home. Okay, this is the result obtained. This is the mite exposure. So about allergen reduction. There were 4 studies, and I present that like a medication. There is the proof of concept, it's published by Carter, the pivotal study, this is the Morgan, I will show you this study, and there are confirmatory studies with Krieger and Eggleston. And this is the most important message, all were performed with asthmatic children. In adults, it's very, very difficult to perform allergen reduction. It doesn't work. Until now, we didn't get any positive results. This is the pivotal study published by Morgan in the New England Journal of Medicine in 2004. 900 children. They were moderate to severe asthma. They were children coming from inner city children, so 2 years of follow-up. And also these children, they have GINA 4 asthma because they were hospitalized very frequently. They were hospitalized in the emergency room. And of course, they used exactly the medical technician, medical indoor environmental technician, because we presented our results 2 years before they performed the study. And this is the demographic, and you can see that, look at that, these children are really sick. The maximum days number of days with symptoms. In 2 weeks, it's 6 days. The days of wheeze were 4.5 days. The days with the child had to slow up down or stop playing because of asthma, 3.4 days. Though these children, they were well defined. They were sensitized to mite, to cockroach, to mouses. They have an asthma, not well controlled asthma, and they perform a study about allergen reduction, global allergen reduction. That means taking care of the mattress, taking care of the floor, using a HEPA filter, a vacuum cleaner, and so on and so forth. This is the results. They are in the group with allergen reduction. In the first year, you have a clinical effect. The days with no symptom, first year, and the second year the same. So the percentage of reduction was 19%. The school day missed was 20%. The unscheduled visit for asthma was 13%. So now the last stage of the study, we demonstrate that using an indoor technician is useful for compliance, is useful to decrease the allergen exposure, but they demonstrate that it's clinically efficient. And they performed it. It's a publication from Crocker, 20 studies, and the reduction with children, always with children, they obtained, when they gathered all the study, a reduction of 21 days with symptom per year, a reduction of day missed because of asthma 12 days per year, and the reduction of emergency visit of 0.5 per year. I just put that, of course, it's not comparison, it's not reason. En français, on dit comparaison n'est pas raison. That means, but this is the result obtained with Xolair. In the Xolair, for example, the pivotal study with Xolair, of course, within adults, the reduction of the emergency and the severe exacerbation, 0.5. So it's not ridiculous. In children, allergen reduction works very well. Post-marketing study in France, it's of course it's open study, and we obtained a very good, more than 50% of the patient, they have a reduction in their symptoms. Of course, it's open study. In some states in the United States, the indoor technician are reimbursed by the private insurance. And this is interesting because I showed you the first study of the English from Kustovic and Ashley Woodcock, a negative study in adults, and they performed a study in children. It was in 2017. And children, for more than 400 children, they were asthmatic, they were sensitized to mite. And the principal objective is to assess the effect of a mattress cover on severe asthma exacerbation, hospitalization, emergency visit, and oral corticosteroid. And it worked very well. They obtain the time necessary to have a severe exacerbation. Here you have the active, here you have the placebo, and you look at this difference. I think there are a lot of drug companies will be very happy to have this difference. So it works very well. Now the future about allergen reduction is phenotyping the children. You know maybe the publication of Jocelyn Just, and she found for the group of 6 to year old different groups, and you have the group of asthma with severe exacerbation with multiple sensitization to aerosol allergen, food allergy, and eosinophils. The second group, more neutrophils, asthma obstruction, and the third group, mild asthma, less sensitization, asthma control with inhaled corticosteroid. And you can, if you try to imagine what would be, in which group allergen reduction will be the most efficient, you think that the group 1 and the group 3 will be the good candidate. And also you can perform cluster study with the dwellings of the patients. And we did that in Strasbourg. We took a population of 300 patients, adults and children. They were allergic to mite, they have rhinitis or asthma. And we wanted, so they have the same label, the same medical label. And we wanted to know in which environment they live, if they have the same environment or not. But in fact, it's very different. For example, we have 3 groups, but I will show you 2 groups. The group 1, it was a urban, not suburban area. They live in an apartment. They are polysensitized, cat, dog, brooch. They are rug, carpets, green plants, good ventilation, mechanical ventilation, and they are exposed to mite, and they have mostly rhinitis. The group 2, they are patients living in urban, suburban, public housing, so less the people who are low income, central heating with gas, use of chemicals, insecticide, perfumes, essential oils, visible molds, active or passive smoking, recent painting, less exposed to mite, and they have asthma. And this is, if you compare the 2 groups, you look at that, the natural ventilation, you look at the plants, you look at the tobacco smoke, passive smoke, the insecticides, and this in the first group in which there is less chemicals, they have mostly rhinitis, and the group who they are more chemicals, they have more asthma. They have the difference. They have really more asthma. There was no difference between children and adults, but it's very interesting. Yesterday, I told you that, in fact, the exposure, it's a mixture. It's a mixture. Of course, they are there, the allergen, but you are also the chemicals. And here is the illustration of one. It's very interesting to visit the patient, because without visit, you can't find that. Secondly, it's very interesting also to consider all the environment as a global environment. In conclusion, sorry, I missed my slides about desensitization, but we can talk about that. Recently, large studies demonstrated that the efficacy of desensitization on mite allergic asthma in adults, on asthma exacerbation and corticosteroid sparing effect. These studies are particularly efficient on moderate to severe asthma, which represent a real change in the identification of desensitization in patients. Of course, in the future, we need to perform studies in children. The studies are going on, I think. Tertiary prevention appears to be effective. So in children, using the indoor technician, and this has been validated in France and United States. And the problem is also to target the right population of children. But I think right now we need to target children and young adults, and I think we need also to be carefully to assess also the indoor environment. I would like to thank the people in my department, particularly Martine Ott, she's the first indoor technician, and also Audrey Dazy, and who helped me a lot for that. And I would like to, this is all the people for occupational asthma. Yeah, sorry. Yeah, thank you.